Hello, everyone. Welcome to OBHealthy, the Doctor's Lounge. We're a group of Black physicians, and we're here for two specific reasons. Number one is to improve health of people who are of African descent, and number two, to encourage young Black males as well as females to go into medicine because we really need you to take care of our community. Understand the webinar is every second Saturday at 1 o'clock. And all you have to do is go. I know those of you who are on right now understand that you can just go to OB Healthy and click the doctor's tab and you'll come up. But please tell others because it takes a community for us to really do this in a big way. All right. And we want to reach as many of our people as possible to help improve, their health. If you want to see our prior webinars, all you have to do is go to the website and hit the YouTube channel, or there's a camera on one of the pages, and it'll bring up all of our past webinars. We have many different topics, and please take advantage of this because they're put together for you. All right. Remember to subscribe once you're on YouTube so we can continue to bring that to you. All righty. Don't forget, and please don't be shy to type your medical questions in. No question is too large, no question is too small. Please, we want your medical questions because we're here to answer them. I'd like to thank OB Healthy for allowing us to bring this to you. Without them, believe me, we could not bring this webinar to you. The most important thing I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, truly, only your doctor can appropriately take care of you from a medical standpoint. All right. What I'd like to do is I'd like each physician to introduce themselves. I'm going to start off with Dr. Duncan. Could you introduce yourself, Dr. Duncan?
Sure. Good afternoon, everyone. My name is Matt Duncan, current fourth year psychiatry resident at Ocean University Medical Center, and future addiction psychiatry fellow at University of Pennsylvania in July.
Excellent, excellent. Dr. Sprock, please.
Kendall Sprott, retired pediatrician, did both general pediatrics and 15 years of critical care pediatrics.
All right, thank you. And we have Dr. Montgomery, please.
All right, good afternoon, everyone. Thank you, Dr. Bayes. I'm Matt Montgomery. I'm a cardiologist specializing in interventional cardiology as well as advanced heart failure and transplant cardiology, working at Newark Beth Israel about the past 6 years.
All right, thank you. And we have a special guest. Well, first, let me introduce myself. I'm Omar Bey. I always forget. I'm Omar Bey, a retired pulmonary critical care physician, and now I'm Director of Nutritional Support at Beth Israel Medical Center for the ICU. All righty. And we are so privileged and proud to have Dr. Cynthia Page with us today. She is well known in New Jersey because she is our past president of New Jersey Medical Association, and hey, hey, hey for the New Jersey Medical Association. Cynthia, thank you, number one, for taking the time to come on the webinar. Number two, I would like to just step back for a minute and just have you tell us how you got where you are today, why you went into medicine, what you like about it, just to encourage those young people out there that may be thinking about this career.
Thank
All
you,
right.
Omar. Honored to be here with all of the fellow physicians here. I'm Cynthia Page. I'm a family physician, and I started my physician career in New Jersey at New Jersey Medical School and then stayed on at the faculty for 20 years. But I got started in medicine really in my 10th grade class, my 10th grade biology class. And we had to dissect the worm. And my partner did not want to touch the worm. So I told him, well, no problem, I'll do it. And so I dissected the worm. And then that really just started my curiosity for biology, my curiosity for understanding organisms. And I just wanted to get to human beings at that point and understand, well, what's inside of human beings if I could understand what was inside of the worm. So that's where I got started in Montclair and then finished early from high school. Stumbled on general chemistry, and that was, first semester general chem was horrible. And so I said, okay, I got a D, I think. So I refused to take Chem 2 and went down to DC and took Chem 1 and Chem 2 over the summer. And at that point, really reestablished my commitment to becoming a physician. I took 2 years off between undergrad and medical school, had various jobs and worked and studied for the MCAT. And by the time I got to medical school, I knew there was nothing else I wanted to do. So
Excellent.
some of my peers were moaning and groaning, but I said, no, this is where I want to be. And now, over 30 years later, this is where I love being.
Excellent, excellent. I'm telling you. Well, we all appreciate you, Cynthia, because you've affected so many people's lives, as well as the young physicians that you've trained, and so many of us, just lean towards you for your knowledge. So I'm so happy to have you today, and our topic today is perfect because it's something that is out there that's new. And when something is new and it seems to be, the best thing since French bread, sometimes it's just not as glamorous as it may seem. So even though it may help, there are certain things that we need to know about. And I'm talking about some of the weight loss medications, the new weight loss medications that are out there. And I'm sure Dr. Montgomery will be able to chime in because I have an example of just a gentleman that was losing weight so rapidly that he got dehydrated and he came into the ER and guess what he had? He had his AFib went crazy. He had RVR and he's hypotensive, all of this stuff simply because of, the weight loss drugs. So there are many things that can occur. But Cynthia, I know this is what you talk about. I want to let you jump into it. Just start it off, and maybe we can just bounce off different things as far as the other physicians, and we can just have a great discussion about these medications, weight loss, diabetes, hypertension, heart disease, the psychological component to it that of weight loss, things like that. I think we have an excellent panel to talk about all of this, but I'll let you start off and introduce it the way you'd like to introduce it.
Okay. Well, right now, Omar, I'm the Senior Market Clinical Director for ChinMed and GenCare in Louisiana. So all of our patients are Medicare patients. So generally, they're over the age of 55. Most are over the age of 65. And the GLP-1s, the Ozempics, Mounjaro, and those medications were not studied in senior populations. So they were not studied in people, for the most part, over the age of 65. And so I was seeing a lot of our physicians prescribe these medications, and the medications have serious side effects and probably more pronounced as you get over 50, because they do cause a loss of protein called sarcopenia. And so, people talk about Ozempic face, and that's where, you start to lose temporal wasting, right? So for all of us like Dr. Sprott and you, Dr. Bay, who grew up in the era of HIV and AIDS epidemic back in the 80s and the 90s, we talked about temporal wasting a lot. And that was just really severe sarcopenia. And so we start to see that, and that's what causes that drawn face with people on GLP-1s, is that they're losing protein. And so we know as people age, generally they have a loss of their protein mass. And so you put something like this into their bodies, they have a more pronounced loss of protein and muscle mass. And so that's one of the key side effects that we see in our seniors. And as we get older, we also lose bone mass. And so bone mass is dependent on your genetics, but also your activity, your weight. And so as you lose muscle mass, that's going to cause you to lose bone mass as well. So our people who are at risk for osteoporosis are now more at risk for bone fractures as a result of this. We had one patient who actually developed renal failure, ended up on dialysis. And we know that the renal failure that can come from the GLP-1s is not reversible. So you know, I started cautioning my physicians early with regards to GLP-1s and to understand what are the mechanisms of action. One of the other things that we don't talk about a lot with GLP-1s is the psychological component as well. So it's described as a blunting of joy. So it doesn't, you know, I've never seen specifically, and I'd love to hear your thoughts on this, Dr. Duncan. Never seen anything with regards to depression, but we do know that it alters mood as well, and it alters cravings, right? Which is why, in addition to slowing down the motility of the gut, it also has an effect on the limbic system as well as to how we have decreased cravings for not only food, but possibly other substances as well.
Cynthia,
Interesting.
could you help explain why there's a protein loss when you're taking these medications?
There's such severe weight loss, and if you're not balancing that with exercise, that severe weight loss is almost like starvation, right? So we're putting a drug into people's bodies and without them fully understanding the side effects of it. And because of the severe weight loss, you're also getting protein loss. And so I haven't seen anything from the mechanism of action as to why it causes such severe protein and muscle mass loss, Dr. Sprott, except that it's just causing that severe weight loss in general.
You know,
Now,
the
I
thing,
know,
go ahead.
that in general, when you talked about renal failure, um, sort of the leading cause of renal failure in the country has been related to type 2 diabetes, which is usually related to obesity. And it's almost um, a given fact that if the longer that you remain sort of uncontrolled and with excessive weight gain, that you end up having renal failure, going on to dialysis. And I know in our community, the dialysis centers are, almost as prominent as the pharmacies around in terms of the numbers. And so one of the aspects that we know about in terms of the obesity and the obesity onset kind of diabetes is that there's an increase in the amount of insulin that the body produces. And one of the ways that you kind of might treat yourself is to decrease your carbohydrate intake and become ketotic, which causes you to lose weight, specifically fat. But once you start to not have the carbohydrate, which is the source for sugar and glucose, is that the body breaks down protein. It breaks down fat, and so that's a good thing. But it also breaks down protein because your body has to have a certain amount of sugar. And the way that you get sugar, if you don't have carbohydrates or sugars that you have in your diet, is that you make sugar or glucose by breaking down the protein and you're able to make some glucose. So in those individuals who sort of take the Atkins diet or the low carbohydrate or the keto diets, and you see all these food products now that are zero carbs and keto this and keto that, is that one of the consequences of that is indeed protein breakdown. And the protein breakdown, especially for those of us who are aged, who don't exercise as much, or hopefully, I try and exercise more than just a little, but it can be a problem in terms of muscle breakdown as well as other proteins, and it can be very, very significant. And the other aspect is that there is this, and maybe Dr. Duncan talk about it, is that there's this desire to look a certain way. We have all these social medias that say you need to look a certain way, and even individuals that are not so overweight, okay, want to lose weight, and even though there's not a real indication, want to go on these drugs in order to do so. And it's like, well, can't you just do it the old-fashioned way? I mean, Omar, we talks about this a lot in terms of
Yeah.
diet and exercise, but the most important component is diet, and that's to reduce your caloric intake. but
Mm-hmm.
everyone wants a quick fix. And I've seen individuals, even in my family who say, well, I want to be a size this and I want to be a size that. And I want the Wegovy, I want Ozempic, and what do you think? And I said, I don't think that you ought to use the quick fix, which is a pill, because again, there's not a whole lot of study, and people, because they've
Mm-hmm.
seen people lose weight, they just say, well, I want it, I want it, I want it,
Mm-hmm.
and not have to work hard because it is hard work to maintain a lifestyle change in terms of your diet.
Mm-hmm. Mm-hmm. Mm-hmm.
So
Yeah,
what are
yeah.
your thoughts about, this individuals that aren't so overweight that want these quick fixes?
Cynthia,
Duncan,
you want
take it
you
out.
want to?
Let's talk about this
Oh,
of
Dr.
your
Duncan,
weight
he's
loss.
going to go
Sure.
next.
Yes.
Sure.
There's a lot to talk about.
Yep.
We
Yep.
all going to get our chance here. Go ahead, Dr.
Okay.
Duncan.
So there's a couple things wanted to address. So I think I want to say, hey, Dr. Sprott, it's been a while. First, but
Yeah, I'm the
I think
old
it's
guy in the bunch. Both Cynthia and Omar came under me, and you were the youngest of the bunch.
He is the esteemed scholar of the bunch.
There you go.
well, thank you. So I think one of the first things we want to talk about is, you had highlighted like the the want for like this quick fix, and really with regard to how our society is, the kind of societal pressures that my generation and generation behind us have. There's such an access to these variables like social media, so you're seeing the end product of things, and people are not particularly very honest about how they're getting there.
Mm-hmm.
So you have women who have gained some weight, being pregnant, and then they show these post pregnancy photos where they have lost all this weight already, and people are looking at this, and this is their expectation. Yet this is not, they're not talking about what they've done, or these are delayed photos that they're showing, etc. So there's really an unrealistic idea of how weight is lost, or what is going into weight loss. Additionally, you have things with regard to drug companies that really, it's like, you're feeling sleepy, here's medication. For us, it's like you feeling like you can't sleep, here's trazodone. There's an idea where they're just things that you can get for a quick fix. And because of how drastic weight loss can be for some people with things like Ozempic, there is a want, because weight loss historically has been so difficult to actually achieve. Um, the the issue with this is that, as Dr. Page is going to talk about today, and a lot of us understand, one, there's not a lot of if you want to talk about long-term studies about what is going on with regard to the long-term effects of use of Ozempic and other GLP-1 medications, but also even with regard to some of the side effects that you can have now, or even if you are getting these medications in some kind of boutique company where you're getting the wrong dose. I mean, I have gotten patients outpatient for, like, in my outpatient psych office, and also when I was on floors doing rotations in inpatient medicine, where patients are starting these medications and having like severe vomiting or severe constipation because they're on too high of a dose. So those kinds of dangers are not talked about either.
Mm-hmm.
Um, there is an issue with regard to that. So that's the first thing that I wanted to comment with. When we talk about like the psychological components, and there are several of them to highlight, there are some studies, and again, they're very new. One does talk about a correlation between, if you are comparing use of Ozempic, for example, as compared to placebo, with patients, they tend to score less on a depression scale. So there is some evidence showing that there can be a decrease in things like depression. There is new language now. I know with regards to the FDA, we kind of look at them with a side eye because they're some of the things that they're producing are questionable. But along with the FDA, the European Medicine Association, they both agree where they're looking to withdraw language with regard to increase in suicidal ideation or suicidal behavior when taking these medications, which shows that there is a level of improved safety, which I think is important. When we talk about substance use, and that's my bread and butter, that's what I'm interested in. There has been some studies talking about the use of low dose Ozempic and cravings for alcohol, also the amount of drinks of alcohol for those with substance use disorder have decreased. It clearly shows that there needs to be more studies in it, but it's very positive with regard to now having something where you can use this, and yes, it's addressing diabetes and or weight loss, but things don't happen in a vacuum. So you may have somebody who has issues with substance use, and you're talking about alcoholism, and it really helps with regard to alcohol use disorder. So it is promising in certain aspects of medicine, certainly, but there's more studies need to be done.
I have a question. Dr. Duncan. When I think about weight loss, I think about that obese or that overweight person where food is actually something that they can control. That's a joy for them. Now you've given them something that takes that desire away. What do they replace that with? I mean, eating is, I mean, truly, eating is such a, how should I say, such a necessary function for some people. If I have
Everyone has to
problems, I'm
eat.
going to eat. If whatever happens, I got to grab a bag of potato chips. So if that's gone away, what do we replace that with? Are these people having long-term psychological effects because that normal process of eating is not there anymore?
So that's a great question. So I would actually go as far as to say for some, eating is therapeutic. So, you talk about, even if you talk about things like soul food, for example, and really how it came about. It's a time where, you get to enjoy food. You get to enjoy this kind of food. It's actually helping with regard to how hard the day has been, or you had a hard day at work, or there's issues with family, etc. But you get to come together and you get to eat this food, and it tastes great. It may not be particularly healthy for you, but you're still eating it because of that. It's extremely difficult now if that was your way of trying to cope, or that was your therapy, and now you have to change it. So I would go as far as to say, again, when it comes to weight loss in general, there is the physical component where you're not just losing weight. And one of the things they talk about with weight loss is you shouldn't just look at the weight loss. You look at, are you fitting your clothes better now? Do you have less knee pain? Do you have more energy? These are all things that you need to look at, because weight can be a yo-yo, just evolutionary, because if your body sees that you're losing a ton of weight, it's going to fight against you, because it's really an evolutionary thing where you want to keep those nutrients, because now it's like, well, crap, your resources are low and that's why you're losing weight. So I'm going to try and not lose weight now. Sure. Um, but there is definitely a psychiatric or psychological component where behavior has to be addressed too. So we did talk about this last webinar, where it was like, if you're getting like bariatric surgery, for example, physically your stomach is going to be smaller, so you can't eat as much. But mentally, you have to sit down and really have some psychotherapy about understanding you cannot eat this much, or you're going to make yourself sick. If you don't, you're going to make yourself sick, and there's going to be problems with regard to moving forward in the process. So my biggest thing, and what I would say, is it's a great question. How to address that is again, talking about it and really having a patient understand, yes, you can have significant weight loss with this, but your behavior is going to have to change, or it's going to be really awful for you trying to navigate this new kind of lifestyle that you're having.
Excellent.
So,
Dr. Montgomery, I see your hand up over there. Go ahead, brother.
no, just wanted to add to this and just to take a little bit of a step back and talk about part of the reason that has been driving this need or this want for weight loss. And, we've talked about the psychological component, and we've talked a lot about sort of just longing of patients and physicians that are pushing that, but a lot of it is driven towards reducing the risk of cardiovascular disease. And we know that cardiovascular disease, obesity, specifically morbid obesity, is a large driver and a huge risk factor for having cardiovascular disease in general, or even new onset or early onset cardiovascular disease. This risk factor, along with hypertension or high cholesterolemia or family history, other things of which I say some you may not be able to control, but of the modifiable risk factors, it definitely is one of the major ones that is driving it. And so there's always been, even when we learned in medical school, we want to make sure that individuals are, eating healthy, eating balanced meals, exercising, things like that, that we always recommend for
I think he
Oh,
froze.
I think yeah. Are you back? You froze there for a minute.
Oh, I'm sorry. Okay, can
Yeah,
you hear me? Sorry, I apologize. So as the obesity epidemic had
oh, he froze again. All righty. I don't know. We have a bit of a technical problem there. We'll see if we can correct that. Uh, Cynthia, do me a favor. Let's just look at this. Um, there are certain medications that are coming out that are in this family that are by mouth. Not the injections, but by mouth. Now that's the new thing coming out. I know Nova has their pill out right now. Lilly's pill is coming out in a few months. That takes it to a whole new dynamic.
Totally
Where
new,
are we going with that one?
totally new dynamic. And sometimes I step back and I think about the science of it um, and think about, well, where could this go, right? So we have now a pill that, the stocks for Lilly are skyrocketing, right? In anticipation that this drug, which has now been fast tracked by the FDA, is going to be available to everyone. So we have a pill that will cause you to basically go into starvation mode, will have psychological effects, whether they be directly from the drug or indirectly from the societal aspects of not being able to eat, and Dr. Duncan, when we talk about someone coming to the dinner table and not eating, right? There's a huge, it's like societal impact of that. And because you look at them and like, why aren't you eating my food? Right. And so, it's something that's going to be huge. And stock market knows that it's going to be huge. Stock market knows that it's going to be well liked by people who can buy it. Um, I think that we have to continue as healthcare professionals talking about the benefits of the drugs. And I think that there are some people who are ideally suited for these medications. And I think that there are others who may take it and none of us know the long-term effects of the drugs. And so that's the scary part for me, is not knowing the long-term effects of a medication. There's supposed to be newer studies that will include seniors and people over the age of 65. But there are a lot of unknowns. I do think that there's an area where this can be used safely. But I just caution people, and I know young people who are taking it, and they've been on it for a couple of years now, and I just caution them, like, okay, well, when do you want to come off? And or people who want to go on it and say, okay, well, what's your time frame? And it's almost like you need psychotherapy, just like when we were talking about bariatric surgery. Everyone had to go through psychotherapy prior to having surgery. And I think that those types of discussions also need to happen when we're putting people on a GLP-1 or a GLP-1 combination drug, because we have to look at what's the end game here. Is this something that you plan to stay on for years? Is it something that you want to use to jumpstart your weight loss, and you're really going to combine it with dietary changes, exercise routines? I think that that's just key, and I don't see those conversations happening. We have pushed our physicians and nurse practitioners to have those conversations because we put them through a process prior to prescribing the medications, looking at the potential for side effects. So, do you have a person who already has constipation? Of course, if you're having any type of thyroid cancer, you can't be on it for that. Do you have a person who already has osteoporosis and you're putting them on this medication? And so I think we just have to use it cautiously, Dr. Bay.
Right, right. Dr. Montgomery, I didn't mean to cut you off there. Can you go ahead and finish your thought, please?
Oh, sure. Apologies. I'm not sure. My internet is misbehaving, but no, I just wanted to just emphasize the cardiovascular effects that we talk about when we speak to obesity, and not just obesity, but the other aspects such as hypertension or dyslipidemia or diabetes, which all contribute to the increased risk of developing worse cardiovascular outcomes, whether specifically heart attack or stroke or peripheral arterial disease. And specifically, even what I deal with mostly is heart failure. And so when we talk about heart failure specifically, there's two types of heart failure. One, where the heart function has the inability to be able to squeeze properly, and you have a decreased ejection fraction, which can cause a lot of issues, but also
Dr. Montgomery, we always like to sort of help our audience deal with these medical terms. Could you spend just a second talking about ejection fraction?
Sure. So ejection fraction is the way in which we adjust, or the way in which we evaluate how well the heart is pumping. And we look at that by looking specifically at the left side of the heart, or the left ventricle, which is how we all have assessed the overall strength of the heart muscle. And so a normal ejection fraction would be about 60%, which means that about 60% of the blood that enters that particular chamber with every heartbeat is pumped out into the systemic circulation. And so that happens with every heartbeat. Anything that's less than that typically is considered to be heart failure. Now that's by reading on the echocardiogram or the ultrasound that's performed of the heart. And depending on how low that is, that can manifest in clinical symptoms such as shortness of breath or lower extremity swelling, etc. But that's just one type of heart failure where the heart function has inability of squeezing. A different type is when the heart.
Well, just one second before you go beyond that. Could you just spend a minute about the mitral valve, which is the valve between the upper chamber and the lower chamber, and what happens if it's not working functionally, and some of the blood that ought to be going out the ventricle into the systemic circulation to the brain and everything else goes back up, and less blood is coming out to go to the parts of the body that really need it?
Sure. So, that is if you have something what you're describing is called mitral valve regurgitation. And essentially you can have a kind of leaky valve is the best way to think about it, where that valve separates the top and bottom chamber of the left side of the heart. So the left atrium and the left ventricle. And so if the left ventricle either has decreased function or weak function, or even in some cases the function can be normal, and you have an issue with the primary aspect of the valve, whether or not there's an issue with the valve leaflet, etc., you can get blood flow going back in the opposite direction. And when that happens, that means you have less blood flow going out in the proper direction through the aortic valve, and you can, in some cases, get decreased circulation to the rest of the body, which can, manifest in a lot of different symptoms, such as, issues with kidney perfusion or liver perfusion, or even issues in very, very severe cases of lightheadedness or dizziness, or even passing out. These are severe cases, but cases that can happen. But oftentimes when the left ventricle or that heart function is weak, by definition, because it's weak, you will sometimes get blood flow, get a mitral regurgitation, or blood going back in the opposite direction. And so that's specifically that type. But when it comes to obesity, specifically with these GLP-1s, when it comes to obesity, you can have a decrease in the heart's ability to be able to relax, which is determined to be heart failure with preserved ejection fraction. And about 80% of patients that are obese do have this inability of the heart function to be able to relax. And that can cause a lot of the same symptoms, such as shortness of breath or, extremity swelling in the legs, etc. And when that does happen, it's very difficult to treat because there's not a lot of medications or not a lot of other defined treatments in order to treat this. But the ultimate manifestations of this can be the same. You can still have similar cardiovascular, difficulties such as, worsening heart failure. You can still have uncontrolled high blood pressure and all these other risk factors associated with that can worsen your or increase your risk of having, major cardiovascular events as heart attack or stroke or peripheral arterial disease. Now, when we talk about these GLP-1 medications, one of the important factors has been that there has been a recent study that was done which showed that one of the particular GLP-1s, and we believe it was tirzepatide, that actually had pretty significant, that had improvement in being able to treat these patients that had these heart failure with preserved ejection fraction, which is a very specific type of heart failure. And so when we talk about really these drugs and everything else, it's important to talk about competing risk and talk about how we're going to really, not just being on the drug for weight loss, but are there actually medical reasons that you can benefit from being on the medication? And I agree, counseling before the medication is prescribed and going through a lot of other the other workup, such as dietary and meeting with nutritionists and even a psychologist or psychiatrist prior to prescribing these medications, similar to undergoing bariatric surgery, like was mentioned before. I think that's incredibly important. But when we talk about prescribing these medications, I have found in my practice that patients that do have this type specifically of heart failure, that it has been beneficial.
Excellent, excellent.
One of the things that happens when the heart isn't pumping as efficiently as it needs to, and there's less volume leaving it, is that the body, I say the body in sort of generic terms, think that there's not enough blood volume.
Hmm.
And the way that it tries to compensate to maintain blood pressure is it causes those blood vessels in the arterial system to sort of contract. And it also causes the kidney to retain salt. And when the kidney retains salt, it retains water. And the problem is that that salt and water that's retained can't stay within the blood vessels. And very often what happens is, if it's the left side of the heart, is that they start to accumulate fluid, and that fluid accumulates in the lung. And Omar can tell you that you can have fairly quick weight gain. I have my neighbor who's a friend, who's a radiologist. He gained 10 pounds in less than a week.
Hmm.
And he couldn't sleep laying down. He had to sleep sitting up. And when he came back and they put him on Lasix, he lost 4 pounds in a day and 10 pounds in a week. And all of that was water weight gain and water weight loss. And so your body tries to compensate for things, even though it's fooled by what the actual mechanism is. And the other thing that Cynthia talked about is this whole idea of you go into a starvation mode. Well, starvation mode is usually when you're not taking, let's say, you can store glucose, sugar, in your liver, and maybe for about 8 hours. But a lot of people, after 8 hours of sleep, the glucose is gone. And if you don't eat carbohydrates or sugar, you stay with a low or level of glucose. Your body tries to maintain it. But your body believes that sort of you're starving. And then you break down fat and you break down these other things. And so rather than go into a starvation mode through medication, Omar, you can talk about it, is that a lot of people have gone through this intermittent fasting. And again, intermittent fasting puts you into this ketotic state, or this breakdown of fat state. You only eat food for a certain number of hours a day. And once you stop eating that food, you go into this ketotic and you start to break down fat. And that's sort of a way that a lot of people lose weight without a pill, but through the same sort of mechanism, without using, I'll say, a drug or an expensive drug. And the other thing that you mentioned before is the pill. People are coming out with patches of the medication to do the same thing. So you're now talking about these long-acting medications that last all day long, or these patches or everything else. And it's like, what are we doing to our bodies really? And again, we've heard a lot about the positive aspects of it. And most of the research that's been done on these has been sponsored by whom? By the drug companies that are making these
The
drugs.
companies.
And so, it's not as if I think that they're making things up, but you hear a lot about the positive effects. And again, people want it where it hasn't been studied. The elderly hadn't been studied. They certainly don't study it much in kids, but they're pushing it on teenagers and kids that are overweight and obese. And I liken it to the opioid epidemic. And the opioid epidemic that came around caused a decrease in the overall life expectancy of this country. It was so pervasive that you start to see that. And we've now seen a fairly dramatic stabilization of the rate of obesity and overweight. And I think it's primarily related to the fact that these drugs are just extremely, extremely popular and making extremely profit for these drug companies that are rushing to do it, because so many people throughout the world are overweight and obese, and these medications are not cheap.
Not at all. Not at all. Let me do this, Dr. Court.
Yes, sir. I'm
Hi,
here.
you have your hand up, but first I'd like you to
Listen.
introduce yourself, and then I see you have your hand up for a question.
Yes. My name is Dr. James Court. I practice in East Orange, New Jersey, internal medicine. And my question is, I came late, so the answer may have been obtained already, but the previous speaker did talk about starvation mode. What it is that triggers your body to say not crave food? Is there something that interferes with some mechanism, or is this, how does the drug act in order for you to not to want to eat?
So the GLP-1 molecule, they first studied it in the Gila monster because they tried to figure out, why does this animal eat once a year, right? And so they figured out that it was GLP-1, which is a natural enzyme or compound within our body, and it's degraded within minutes, right? Like 2 minutes. When you eat, your GLP-1 increases. And so these are GLP-1 agonists, right? So they're trying to mimic what happens with the GLP-1. So they figured out, if you take out one amino acid in the GLP-1, that it's no longer broken down by DPP-4, right? So we know the DPP-4 inhibitors, right? And so they function to try to stop the breakdown of GLP-1s. So they figured out how to take out the amino acid in the GLP-1 molecule, and then how to also attach it to albumin. And so now when you attach it to albumin, it circulates in the body for a longer period of time. But the initial drugs had to be injectable, right? Because they still couldn't figure out how to get past the DPP-4 in the gut. And so they were all initially injectable drugs. And so now they figured out how to get around the breakdown of the GLP-1 molecule in the intestines as well, which is why now there's going to be a pill that is just like there was Rybelsus was out there, but it wasn't as effective, right? So Rybelsus is the oral form of semaglutide. And so now you're going to be able to take in a pill because they figured out how to not get the GLP-1 to break down. So once they took out the amino acid, attached it to the albumin, now you inject it. So instead of it lasting for about 2 minutes to decrease your appetite, it lasts for 168 minutes, right? Or 168 hours, which is why it's injectable once a week. And so that's how it works. So the GLP-1 molecule reduces appetite. And that's an enzyme that primarily works in the gut, but we also know that there's an impact, a neuroendocrine impact on the brain as well.
Interesting.
Interesting. Do all the medications work the same way? I know that there are quite a few medications out there now. There's the new ones. I think there are 2 or 3 new ones, and then there were some old ones that have been out for quite a few years. I know some of the medications decrease the urge to eat, That's for sure, with the GLP-1s, how you explained it. But there are others, I mean, and but some of the medications also, along with that, decreases the mobility or how the food moves through the gut and slows that up. Now, my concern with that is that we have diabetics that are obese. And diabetes, how does it work? It inhibits the action of our nerves and our small blood vessels. It interferes with those. Well, there are patients with diabetes, and a lot of patients with diabetes with it's called diabetic gastroparesis. So, how do we, you got this obese patient that has diabetes, that nerves are not working appropriately to stimulate the gut to push the food along, and now we're going to add a medication that inhibits it as well. So, have you seen bowel obstruction or ileus? Ileus is when the, fluids and the food is not moving through the gut appropriately, and these are issues that people really have to come to the emergency room.
Yes,
So
we,
have you
we've
seen
seen
that?
we've seen our patients in the ER who
Mhm.
are on these meds. There are certain studies. There are studies that are being done around the world. There was one study that showed that there was about a 1.5 times risk of having a bowel obstruction when you're on a GLP-1. Some of the other studies that followed did not find that, and so the the verdict is out pretty much with regards to does it cause bowel obstruction. We do know that it will send people to the ER for nausea, vomiting. And then when that happens, right, here's the challenge, right? When we talk about the effect on the kidney, when that happens, not only are you not eating, you're not drinking, right? So then now you increase the risk of acute kidney injury because you're not drinking. And so if you don't have that reserve, right, you're going to get into more trouble because of the medication. And so again, this is where you have to have intense counseling with your patients because they'll come back and they'll ask you to increase the dose because their weight isn't coming off as well as they would like for the weight to come off, and then they start to have more of the side effects associated with the medications. I also caution providers if you have someone who is on an opiate, which also causes decreased transit through the bowel. Now you're compounding the issue. Some discussion with regards to when do you stop a GLP-1 prior to surgery? And
Mm,
so you have people, so it's causing gastroparesis. Are we going to have people that have more constipation and problems after surgery, but also during the surgery and during intubation of a patient? Because do you have, we say, you're not supposed to eat after midnight. Well, is there food still there from 24 hours, 36 hours ago
right.
because of the slow transit through the bowel? And so those are becoming more issues, and we haven't really thought about that in the past when we're clearing someone for surgery, but that has
Hmm.
to be assessed as well.
Yeah.
Is
Just
gastro
from a quick, I'm sorry. Go ahead,
is,
Dr. Core.
is gastroparesis a definite cause of how these medications work?
They slow not only through the stomach, they slow transit through the small intestines as well. And so it's the effect is and there's a belief that it may affect the colon, the transit through the colon as well. So, we've always talked about from more of a, naturopathic, functional medicine perspective, we talk about, how often you should have a bowel movement, right? And we generally think like once or twice a day, right? But these patients may not have a bowel movement for several days. And, there is a side effect, and they say, their breath starts to have an odor, increased odor to it, that they talk about the rotten egg smell. But, with regards to being healthy, we know that you want waste products to transit through the bowel at the proper pace, right? And so when you slow that down, you have waste products that are not being excreted at the pace that we would normally expect someone to excrete.
Looking at it, and you had mentioned this, looking at it from a pulmonary and a ICU or a surgical um, view, if the stomach still has food in it, and it's not moving through. And this is a big issue when going to surgery and intubation. And you were talked about this as far as, the anesthesiologist putting the tube down so that the machine can breathe for you. If your stomach is full, then what we have a problem with is aspiration at that time. The food comes back up and goes into your lung. That is a major problem if this is a issue where the stomach is not emptying appropriately. So that's another thing that we can
Mhm.
think about.
Right. And we have to heighten the understanding of our physicians with regards to the impact of the medication. So, something that never ever spoke about with regards to, optimizing someone for surgery. We
Hmm.
talk about, the blood thinners, when you have to stop those, but now we have to begin to think about the GLP-1s as well.
Hmm. Hmm.
That
Dr.
that
Sprock,
is
your hand.
that is usually
Go ahead.
written. That's usually written for when I have to clear a patient if they're all on GLP-1s also, in
Hmm.
addition to other things that we did know before.
That's right.
Yes, they put that as.
All right. Doc, Dr. Sprock, your hand is up, please.
Yeah, again, James and I are similar ilk, but way back in the day, um, a lot of people used to abuse amphetamines, speed, and
Hmm.
and one of the things that amphetamines um, were used for was not only to get high, but also it was appetite suppressant.
Hmm.
So there was weight loss associated with amphetamine use. And I was just wondering, Dr. Duncan, we talk about these GLP-1s, and I know that, appetite suppression is something in the brain, and since you may know more about what it is, but I'm sure it's related to some of the neurotransmitters in terms of those kinds of things. But I was curious as to whether or not the appetite suppression that amphetamines have are similar to the kind of appetite suppression that these GLP-1s have, and maybe there's some sort of competition that might be in play when you talk about people on GLP-1s not having the same kind of interest in food, or maybe interest in things that are addictive like amphetamines and or alcohol or something else. Any thoughts about whether or not there might be some competition between GLP-1s and some of these other things that affect the appetite?
Yeah. Um, either one.
Go ahead. Go ahead.
Anybody?
If you have any thoughts on it on that aspect, because this, I understand that we still, Dr. Sprock, we still have so much research to be done. But just giving your opinions, I'm not saying that it's written in stone, but do you have an opinion on what Dr. Sprout has stated? You know,
Sure.
um,
So again, I think that's a really good question. I think the we're talking about the mechanism. I cannot give you the exact mechanism. I know when we're talking about satiety, as it's called, or feeling full, that is, do not remember which of the this is the hypothalamus, which one of the subcategories of it that actually affects that. Definitely something
mhm,
I studied for boards and I forgot. But what I will tell you is what is really important is understanding, when we talk about, as you were saying, like amphetamines or speed as compared to, you know, GLP-1 and the situation wise
mhm,
with amphetamines and having that potential for addictive property,
mhm,
because not only is it increasing energy and or concentration, um and then you do have the reduction in wanting to eat per se.
mhm,
um the parallels are a little bit different because I also have had a situation where a patient wanted to restart on Adderall, but in very large letters in there, they were doctor shopping, honestly. So just looking at the soap note from before from another physician,
mhm,
there was an issue with regard to them wanting to use this for weight loss,
mhm,
more than it being something because of schooling. So I think that
Just so
there's
everyone
certainly.
knows, Adderall is a stimulant. It's
Mhm.
used for, I prescribed it, a long-acting Concerta for individuals that had attention deficit hyperactivity disorder.
Hmm.
Mhm.
And Cynthia, who's family medicine, I'm sure has had patients that were diagnosed as ADHD, where it works to help them focus primarily.
Hmm.
But I am concerned about the potential of individuals that are on Adderall for ADHD, then having the issue of possibly wanting GLP-1s, and what that might do, because they're
Right.
in terms of appetite,
Yeah.
they're affecting, and I don't know whether or not they might either interfere or increase the risk of complications related to that combination. And
Yeah.
people very often, and again, I know that everything's on electronic medical records where they want you to give them everything, but not everyone says what they take. And the issue of someone taking a drug that might be competing or might enhance some of the adverse effects of these things is common.
You
Yeah.
know, Dr. Sprock, I think that time and research is going to pan this out, and then obviously it's going to show itself. If it's an ugly head, it's going to rise, and we're going to figure it out going forward. The one thing I could say about amphetamines is that it increases the metabolic rate. And that's another reason that people lose weight, not only because of the appetite loss, but your metabolic rate revs up and you're burning calories faster than you usually burn. I mean, each of us have a metabolic rate where how fast we burn our calories. And you can get one person who's overweight and they can eat one meal a day and gain weight, and you have another person who eats, 3 meals a day, 3 solid meals a day, and is thin as a rail. So we all have our individual metabolic rate, but this is a medication that actually changes that and allows your body to speed up. That's why they call it speed, and actually burn more calories than you would usually do. And your thyroid is actually what sets your metabolic rate. So these are some of the things that kind of throws your body out of kilter so that you lose weight and you decrease your appetite as well. Um, what I'd like to do now, I mean, we're in halftime, so let me do my halftime spiel. Where is it? All righty. Okay. So what I'd like to do is I'd like for each doc to reintroduce themselves and Dr. Montgomery, I see your hand. After we're going to take your hand and we're going to answer a question as well. And please, the first thing I want to say is those out in the audience, please do not hesitate to type your questions in. This is such a great topic, and it's just going to be one that we're going to be talking about for years going forward. So we got to know what your questions are, what your thoughts are. We want to know so we can talk about them and you can join the discussion as well. Dr. Montgomery, please introduce yourself.
Okay, I'm Matt Montgomery. I'm a cardiologist. I specialize in advanced heart failure and transplant cardiology, as well as interventional cardiology, and work at Newark Beth Israel for about the past 6 years.
All righty, excellent. Dr. Duncan, please.
Sure. So, name is Matt Duncan, current fourth year psychiatry resident at Ocean University Medical Center, and a incoming addiction psychiatry fellow at University of Pennsylvania.
Excellent, excellent. Dr. Sprott.
Yeah, Kendall Sprott. I'm a retired pediatrician. I did both general pediatrics and critical care pediatrics.
All right, and Dr. Page, please.
Cynthia Page. I am a family physician and senior market clinical director in Louisiana for GenCare and GenMed.
Excellent, excellent. And Cynthia, I just heard that you got a certificate in AI and medicine.
I,
I've been keeping up with you.
I did. So
Congratulations.
thank you
Congrats.
through
Yeah.
Harvard,
We
Medical
may
School.
ask you a few questions about that because that's another thing that's on the topic.
Okay.
All righty. Dr. Court, please.
James Cord, graduate of Howard University. I practice in East Orange, and I admit patients to Newark Beth Israel Medical Center primarily.
Excellent, excellent. All righty. So you'll understand that this webinar is every second Saturday at 1 o'clock. And please, it takes a village. So tell people about it, tell family members, church members, even tell people that you don't like. Tell them about it as well, because we want everybody to be healthy, all righty? Um, you can access our past webinars just by going on the website and hitting either the camera or our YouTube channel. And all of our past webinars, all the topics are there, and please don't hesitate to access that. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor truly can best care for you from a medical standpoint. All right. I'd like to thank OBHealthy for allowing us to bring this webinar to you, and we are going to move forward. Dr. Montgomery, please let us have your question.
Okay, thank you, Dr. Bay. So we talked a lot about these medications and a number of the issues with them, which we all know exist and are very, very prominent. I think the reality is that a lot of our patients, as well as a lot of the individuals on this webinar, may actually be on one of these medications or anything else. And in our society, if we have something, if a little bit is good, a whole lot of it is better. So if you're on, 500 milligrams of this, 1,000 milligrams should actually be better. But I think managing expectations is of the utmost importance when you're doing any of this. And so my question is maybe Dr. Page, if someone's deemed to be appropriate to be on one of these medications for whatever it may be, for weight loss or anything else, what's the appropriate amount of weight that they should probably be seeking to lose? And then what happens when, they've lost that particular amount of weight and they're actually point a decision of maybe being taken off of it? What's the expectation there, and how much of a impact is weight gain after that?
Thank you, Dr. Montgomery. Great question. So when people are going on, I do ask them, where do you want to go with this? What's your goal? Some people, I'm recommending that they take it, especially when they're getting to the point of needing to see cardiology and not being able to exercise the way they should, or they have leg ulcers. And I know that the only way this person is going to lose weight and stay alive potentially is to have rapid weight loss, right? We have to get the weight off. So those are the people that I recommend easily a GLP-1, and of course with conversations about how do they use it safely. Other people who are going on, I'm asking the question, well, how long do you plan to be on this? How much weight would you like to lose? How are you going to combine it with diet and exercise? Because I have them look at any medication I would use for weight loss. I used to prescribe the phentermines, a lot before we had other options. And so, I would tell patients, this is just a crutch, right? This is nothing that you're going to stay on forever. This is just something that helps to jumpstart your weight loss so that you can then continue on and lose weight. But while you're on it and it's decreasing your appetite, you have to control the types of food that you're eating while it's reducing your appetite. So you can't keep eating the foods that are going to be obesogenic, right? That are going to cause weight gain. You're going to have to decrease those substances, whether it's juice or food or whatever it is that you're eating, in order to maintain the weight loss. And then I look at some patients who have lost 30, 40 pounds, and I'm like, okay, when do you want to come off? What's your next step? Right. And so generally I'm urging along the way, to reduce. And so we start to taper the medication. So I don't generally just take them off of the meds, we taper it down. And then, it's like, okay, well, let's see how you do. Let's see if you maintain your weight loss. And if they're able to maintain the weight loss, we're tapering it down even more. If they start to regain the weight and they are able to exercise and eat a healthy low carb diet, which is very expensive. All right. So a healthy diet costs more than an unhealthy diet. So then it's a matter of having that discussion about, okay, well, it's time to stop. Let's stop and let's see how you maintain your weight loss. Like with other drugs, people regain their weight, right? Even with bariatric surgery, we knew that, after 2 years, people were going to start regaining some of the weight. And so the goal was to get them to their goal weight and change the behavior so that they don't regain the weight. But people will regain the weight. The big question is going to be, do they have GI side effects after they stop taking the medication? And I've seen some people who've been off the meds for a year and they're just, they still get a little bit of nausea. So I don't know what the long-term effects are. No, I haven't seen any study that's telling me what are the long-term effects of these medications. But I put people on with the expectation of taking them off.
Mhm. Excellent answer. Excellent. Dr. Court, please, your hands up.
Yeah. My question to Dr. Page and or Dr. Montgomery, is there any role for, say, combination of phentermine, which is a medicine that myself and Dr. Sprott knows all about, for weight loss with any of the GLP-1s? Since there are different
No,
mechanisms.
no study. So the amphetamines are more dopaminergic type of drugs and noradrenergic drugs. So they work by a different mechanism. The challenge is, you might end up having to send your patient to Dr. Montgomery because both drugs raise the heart rate.
Yes.
So GLP-1s have a modest heart rate increase, and the amphetamines we know can have a significant heart rate increase. The two together, they're going to have to pick one or the other.
Excellent, excellent. Dr. Sprott, please.
Yeah, it was asked of Dr. Page, but Dr. Montgomery asked a question. And this is something, as a pediatrician, you look at children that are growing and developing. And what we normally do is we do percentiles. And when the percentiles of height, which are usually genetically related, or you look for proportionality. So if someone's at the 75th percentile for height, they're going to be proportional if they're at the 75th percentile for weight. And so you like for those percentiles to be the same. Now, there are issues related to the percentiles that complicate things. And so one of the things that you can look at is for some of the athletes, okay? They may be at the 75th percentile for height, 75th percentile of weight. But you need to start to look at, well, what's the body fat percentage? And I think that's sort of important. And so you might say for men, the a healthy body fat percentage might be 24 or 25% of the weight. For women, they have a body fat percentage that can be a little higher, maybe 30% of their weight might be fat because they carry fat in places that men don't, which is a good thing. But I think that when you start to look at that, one of the things that is important here is the muscle mass. Okay. And so some of the athletes may have body fat percentages that might be 15% or 10%. And there you can see you see their six pack because the muscles that underlie the fat you can't see depending upon how much fat you have above them. The smaller amount of fat that you have in terms of body fat percentage, then the more you can see the muscles that are underneath them.
Mm-hmm.
And so one of the problems with what we're talking about is protein breakdown. And when we talk about protein, you're talking about the protein that's in muscles. And so what you don't want to have is someone to have an increase in their body fat percentage as a consequence of a decrease in their muscle mass, if you will. And so when we talk about trying to come to a desirable weight, you need to take into account what their height is, what their weight is in terms of proportionality to that, and then their body fat percentage. And people want to look a certain way. Some people may never look the way that they want to. And you'll see all these folks that are doing, adding stuff to their behinds or adding stuff to other places. But what you really want to have this occur in a healthy way. And you need to have the folks pay attention to the things and to have a body weight that's proportional to their height and also a muscle mass that's desirable. And
Hmm.
so the goal is, well, to the patient is what do they want and how do they get there in a healthy way without sacrificing muscle mass?
Hmm.
Because over
Yeah.
time, we all, as we age, tend to lose muscle mass, but you can
Hmm.
maintain it through exercise. And you can
Hmm.
adversely affect it by having diets or medications that are going to break down protein.
Yeah, let me just add to that, Dr. Sprout. We always talk about muscle mass, but when we talk about muscle mass, we mean more than just your the muscles that you would, be lifting weights and trying to build those big muscles. We're talking about our internal organs. So you're talking about the heart, you're talking about the liver, you're talking about the kidneys, you're talking about that those organs need protein. And if it's not getting enough protein into the body acts as the first thing it's going to do is break down the muscles outside of your primary organs. So it's going to break down the muscles like of your arm and your legs and stuff like that to preserve those muscles those organs that require protein. So it will break your strength muscles down to preserve your heart, to preserve your kidneys, to preserve your liver, so that you will have that proteins broken down to amino acids. You will have those amino acids such that those organs won't suffer. So you can get pretty thin in the muscle region to preserve those internal organs. Understand? So that's just one thing I just wanted
Yeah,
to add on to what you were talking about, Doctor.
yeah, yeah. Really, everyone needs to understand that most of the protein in the body
Mm-hmm.
is within the cells.
Mm-hmm.
And so, Dr. Page talked about albumin, which is a large protein that's circulating, and a good portion of it is made by the liver. But all cells have protein, and part of the internal workings of the cells, whatever they are, specialized cells, is to make the proteins that are special for those cells. But
Mm-hmm.
when you go into starvation mode, I don't think that and there are hierarchies in terms of what gets hit first, but all the cells are going to suffer at a certain
Mm-hmm.
point in terms of the breakdown. Some cells are going to suffer more than others, but all cells, no cell I think is going to get spared in
Mm-hmm.
terms of that whole process. Because your
Right.
body says it's going to take whatever it can from whatever cells
Right.
give it up.
Mm-hmm.
But again, you don't want to be in that um, negative protein balance, I'll say.
Right. True. True. Let's take some questions. We have several questions here. I'd just like to. The first one is, most importantly, the drug companies are not pushing the fact that you regain the weight, that weight loss, and even add more weight when you discontinue the medications. And have you seen that, Dr. Page, that when they stop, there may be sort of a rebound weight gain
They
with some of these medications?
most people will regain the weight. Haven't seen it. It's sort of like with bariatric surgery. I haven't seen it where their weight goes above a lot of
Mm-hmm.
times where it was before, but they usually go back to that original set point of weight. And so if you're not, I know that if I don't do certain things, I will go back to my higher weight, right? And if I maintain my diet and exercise, I can drop it down. But the body's sort of it's partly genetics as well, but the body's always trying to preserve itself, right? And it wants you to go back up a lot of times. And it takes a lot of effort to keep the weight off.
Mm-hmm.
As we talk about from a holistic standpoint, Dr. Bay, there are three things that people do to maintain weight loss. One is they weigh themselves every morning.
Mm-hmm.
Two, they eat breakfast every day, but your breakfast has to look more like your dinner than it does your breakfast. And three is they exercise on average about 30 minutes a day. So
Mm-hmm.
that's how you maintain weight loss. So it's hard to lose. It's probably even harder to maintain weight loss.
Mm-hmm. 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 Yeah. There's another question here, and it deals with some of the peptides. Like it says, "Good afternoon. Can you please touch on other peptides?" And there's one is Tessa Morcellin, hopefully I pronounced that right, the GHK-CU or the NAD question, and most of all are of a fan of they are most of all a fan of stacking peptides. I'm not familiar with this. This is a little outside of what I do. I don't know if Cynthia, you can answer that question or give us some guidelines on that, or
Um,
Dr.
I do a little bit of functional medicine, so I haven't seen these with regards to weight loss. They're part of the SIRT1 pathway. Those two drugs, and the GHKCU is carried by copper in the body. They help to manage oxidative stress, but I haven't seen anything with regards to weight loss.
Excellent, excellent. There are a couple questions, and the one is that, and it really concerns me because I feel that a lot of the patients that may truly get some benefit from this medication or these medications cannot afford them. So, and it just comes down to those that have money can afford them, and those that don't, they continue to have diabetes and heart disease or whatever these medications may help with. How do you handle that with your seniors? I don't know if Medicare actually covers these medications or it doesn't. You know, how do you handle it, Cynthia?
This year, something new. Medicare made it cheaper. Last year, the drug companies were charging about $1,300 a month for the injectables. And so this year, they dropped it to around $360 per month. So depending on whether you have Medicare Advantage or straight Medicare and which plan you have, that will determine how much you pay. But right now we have some seniors who are able to get it with a copay of $20.
Mm-hmm.
There were prescription assistance plans with the pharmaceutical companies last year, but since they dropped the price this year, they've eliminated those pharmacy assistance plans where they would provide it to you free based on your income. But those plans went away this year with the when they dropped the price.
Do you feel that the price may go up once the pill comes out?
The pill's probably going to cost a little bit more. I mean, supply and demand. So
There you
they
go.
might charge a little bit more for it, but and so that's it. Well, that's remains to be seen.
Dr. Sprock, your hand is up, please.
Yeah, I just a comment about the peptides. And again, it all relates to the proteins, which is essential components of all the cells that we have. So proteins are made up of amino acids, and there are different configurations of these amino acids that
Hmm.
determine what kind of protein you have in any particular cell. But the breakdown product of amino acids are these peptides.
Hmm.
And so, on a general sense, when we talk about what the body has, the body's in constant state of, I'll say, equilibrium, where things are balanced. So you are building things and then you're tearing down things. And so proteins are made and proteins are broken down. And that's usually imbalanced, okay? Unless you go into something like starvation, where you create catabolism. So you're breaking down things and nothing's being built because that's the mode that your body's in. And so you can't store proteins. Okay. When you ingest proteins in meats or whatever form, and a lot of people take these protein shakes in order to build muscle, and there's a very little amount of protein that's going to be made in terms of building additional muscle, unless you're doing some exercises where you're tearing down muscle and rebuilding. So when you're rebuilding, you can add on. Okay,
Hmm.
and so peptides can be very beneficial when you're trying to build things up that have already been broken down. But if
Hmm.
things have not been broken down, then there's nowhere for this peptides or proteins to go except out through your kidney.
Hmm.
Okay, and so your kidney is responsible for getting rid of the proteins that are broken down, and you get rid of them. Okay, and if you take a whole lot of protein in, it gets absorbed And if you don't need it, it gets rid of it. So all
Hmm.
this excess proteins or excess peptides that you may be taking with the belief that it's going to be building something good for you is
Hmm.
not really the case. Okay. There's if indeed you have some protein breakdown, then you might need that protein intake in order to replace what's been broken down. And
Right.
so it becomes important, I think, then maybe they'll study it, is if you have someone who's breaking down protein, whether or not they might need supplement either protein or peptides to help
Hmm.
rebuild what's been broken down. But as
Hmm.
long as your body's in this starvation mode, where you need the I'll say carbohydrates primarily in order to stop the muscle breakdown, then
Hmm.
I'm not so sure how good it's going to be. So
Yeah.
you need to be in a spot where you're not starving and you can start to anabolize instead of catabolize, build up protein instead of breaking down protein. And so I think supplemental peptides are good if indeed you are able to build, but you need to be able to build when you're not starving while you're
Starving.
eating and trying to regain something.
Yeah. You know, Dr. Sprock, I know that with your ICU training, you probably did TPNs as well. But my mentor back at the University of Penn, Dr. Mullen, used to say proteins, you know, when we give nutritional support via the IV route with people that cannot eat, and you have to give it in a broken down form. That's amino acids. Because at a peptide stage, it's not going to be appropriately used. It has to be broken down and it has to be amino acids. He used to state that proteins are a black box. It goes in one side of the box and it comes out the other side, and whether how it's used, when it's used, what organs in the body utilizes it appropriately, it's all a question mark. And then what we used to do is we used to get something called the UUN, urinary urinary nitrogen level. And this nitrogen level would allow us to understand whether the proteins were actually used appropriately. And there were many times in patients that were either in starvation mode or not active or not breaking down proteins that they did not utilize the proteins appropriately, as you stated. So I concur with what you said because of the research that was done back at the University of Penn during the time that I was there. Um, Okay. We get some more questions coming up here. But first, I would like to, uh, do you find that, Cynthia?
I'm gonna come back. The alarm is going off. And it's
Oh, my
starting.
goodness. Okay, go right ahead. Take care of the alarm. All righty. Okay. She will be back in a minute. Let's talk about, well, I could talk about a multitude of things, but as far as weight loss is concerned in these GLP-1s, let me just say that back, I don't know, it's been maybe about what, 30 years, 25 years that FinFin was out, Dr. Sprock, back in the day.
Yeah, yeah, oh, yeah, that
Yeah.
was, yeah.
So, and back then, it may have been longer than that actually. It may have been about 30, 35 years. There was medications that actually came out and they were thought to be the best thing since French bread for weight loss at that particular time, and they were called FinFin. All right, FEN and stash PHEN, and come to find out over time, we realized that these medications had serious side effects, and these side effects were pulmonary fibrosis and pulmonary hypertension. So, and the unfortunate thing about this disease, this pulmonary hypertension and pulmonary fibrosis, is that we didn't have and still don't have very good treatment for it. Once you have it, it can be fatal. And the thing of it is that these medications, the GLP-1s, I feel not. I'm not saying that we're going to have those type of side effects, but we're still very early in our stage as far as understanding these medications. And I think even more so with us physicians, we should be educating our patients like Dr. Page does as far as the potential for it to do good and the potential for the side effects to occur as well. So, yeah, Dr. Page, I see you're back with us. I was filling in there for a minute for you. Excuse me.
Thank you. Thank you. That really
Excuse
startled
me.
me.
I had a question. Have you found that patients after about a year they plateau and they get no more weight loss?
Um, Probably yes, but it happens a little bit later with the GLP-1s. They don't really plateau like we would see with the phentermines or the orlistats and all of the other drugs that we used in the past.
Mm-hmm.
Their weight loss really continues. And so, I would never see, 40-pound weight loss in 6 months
Right.
with the other drugs. But with this one, I actually see that. So, and again, you adjust the dose when they have too many side effects or if they're not losing weight. But at some point they should plateau, but we just see ongoing weight loss. And that's when I'm asking the question, okay, when do you want to stop? Is it, have we reached our goal at this point? Because I'm not seeing that same plateau.
Mm-hmm. Mm-hmm. What about as far as losing weight and as far as the cosmetic aspect of it? Now, I know there are probably a lot of patients that come to you and say, I just got to lose 10 pounds real quick. Or those patients that have lost a significant amount of weight and then all of a sudden they looked aged. The wrinkles are in and all of that starts popping up because they lost the weight so fast and now all that subcutaneous tissue is gone and
Right.
they just look old.
Right.
And now
And that's what makes us look young, right? That
hmm
subcutaneous fat, right? So you
hmm
see babies and you just want to pinch their cheeks, right? Because they have all this fat all over their body.
hmm
And so when we lose that, that's what makes people start to look older. And so I think I have some people who look older, but they still want to keep going with the weight loss.
Have you had patients come in, many patients that just is, a cosmetic thing? I need to lose 5 pounds to get into this wedding dress.
We have people who just want to, who have a BMI of 29 and they just want to, lose the weight. So they're not in the obesity category, but they just want to lose the weight. Absolutely. Absolutely.
Hmm
Absolutely.
Yeah,
And I think the higher the income and the more affordable it is for that person, the more likely they would request that.
they will go with it, huh?
And just, Dr. Ray, I'm sorry, I just wanted to add with that, one of the things that I think we've seen in regards to using it for the cosmetic aspect of it is, for patients that legitimately may actually need the drugs are not even available. And
hmm
there's been a large portion of that specifically, I can recall with Ozempic within the last maybe 6 or 8 months prior to now, there was a shortage of it where I had a number of my patients where I had to send the medication to a different pharmacy or anything else because they were on it for medical reasons, but it was unavailable due to a lot of the cosmetic uses of it. So this is one of the unintended consequences, I think, of the cosmetic use of the medication to
Right,
that
right.
extent, let's say.
Mhm. Right, right. Dr. Sprout, your hand is up.
Yeah, just to your previous reference to the fen-phen, it was extremely popular and caused a lot of weight loss. But ultimately, when it talked about the cardiovascular effects and the pulmonary hypertension effects and everything, you do a search for it. I think the company that made it ended up paying 13 to 14 billion dollars
Mm-hmm.
in terms of settled lawsuits. Now,
Mm-hmm.
I'm not saying that Ozempic is like that, but it kind of raises another issue for me, and that is you're talking about something that the body makes, you know?
Right.
Insulin is something that the body makes.
Mm-hmm.
And so, why should, in my opinion, drug companies make an obscene amount of money for something that the body makes? Now, Cynthia talked about the fact that they just took one little thing out of something and then made it last longer than 2 minutes. But it's the same thing that your body made. So the fact that your body made it makes it less likely to be kind of have the adverse effects that some of these man-made chemical drugs have. That's not to say that it can't happen, but I think it
Hmm.
makes it less likely since the body is making it and the companies that are marketing it have altered it in a slight way. And so I
Hmm.
think it's less likely to happen. Still, I think you need to look at it, especially when you look at it being combined with all these other drugs that people are on. And I can tell you that the older you get, the more
Hmm.
likely it is you're going to be on multiple medications. And the drug to drug interactions can be important and not always in a good way.
Yeah, yeah. Do you find, Cynthia, as far as vitamin D is concerned, that there's any interaction?
With the GLP-1s,
Hmm.
I
Hmm.
haven't seen anything. And I'm trying to just think of how they might interact. Why do you ask?
It's just that we as black people, you know how I am. We as black people are deficient in vitamin D because we have pigmented skin and we're not in the sun like we used to be, like when I was in Ethiopia just a moment ago. But
More
uh,
so in Florida than in New Jersey.
yeah, yeah,
In this,
that is true. That is true.
Actually, since I moved to Louisiana, I am no longer vitamin D deficient. So I'm outside a lot more. So, it's that line, right? You draw that line between South Carolina and I think LA, right? If you
There
live
you go.
north of that line, you're more likely to be deficient in vitamin D. You live south of that line, you're less likely to be deficient in vitamin D. Um, but I
and there's a
haven't
lot
seen
more
anything.
comfort food in Louisiana.
Oh, I gained 15 pounds.
There you go. There you go. Well, the thing of it is that vitamin D is such an important aspect for us, and at the cellular level, I was just wondering whether there was if you've heard of anything or seen any research. There
No,
was.
but you know what? You know what's interesting? There was a study, and tell me if you've heard of this, that looked at vitamin D deficiency and colon cancer.
Hmm.
And so, okay, again, we have something that's allowing the waste to stay in the GI tract for a longer period of time.
Hmm.
Is it oncogenic, right? Is it causing
Uh,
cellular change because you have waste products staying in there so long? I don't know, but if I had to write an
Donna,
imagination paper on like vitamin D deficiency and
come here a second.
GLP-1s, and be creative, do some creative writing without the research, that's the direction I would go in. And if I were going to
Can you change
research,
out of
that's the
Cynthia's
direction I would go
page?
in.
Yeah, yeah. Hmm. I am. Yeah, because there are certain things that are just. I just think that two things. One thing was the vitamin D, but the other thing is the diabetes aspect. Because once someone has severe diabetes, there are just so many organs affected. And, I think that, once someone is really overweight for many, many years, the likelihood that they have diabetes is significant, and not type 2 diabetes. I mean, well, type 2 diabetes it can be, but just diabetes that they require insulin, I should say. And I look at the patients that I see in the ICU, and they come in, and especially African Americans that are overweight, I could have a script, history for these patients. They come in, this is a, 55, 60-year-old patient with hypertension, diabetes, heart disease, renal insufficiency. I mean, that my history starts like that every time. So these medications, it's a big concern for me, and I think this is such an important webinar just to highlight that,
Right.
and especially for the African American community, because if you really look at our food deserts and the fast foods and the overweight. I mean, you look at some of the statistics, and like 59 to 60% of African American females are felt to be overweight or obese. That's an enormous number. And when you think about how many of our people going forward will be on these medications and having the complications from these medications, along with the diabetes complications, it's going to be significant. So I'm just so pleased that you came on to the webinar just to to highlight some of these things. Anybody else have anything else to say? I don't want to dominate because I have too much to say about this, you know?
I love hearing you, right? Because we have to begin to think about it from a scientific perspective, from a philosophical perspective, right? From a
Hmm.
societal perspective.
Hmm.
It's obesity is going to cost a lot.
Hmm.
And again, they're the social determinants of health. So when
Hmm.
we're talking about food deserts and not having enough supermarkets, we
Hmm.
also look at green space, right? Is there enough green space in the neighborhood where you can just walk outside and, go walk 2 miles around the park safely and come back home?
Hmm.
And that's what, we have the luxury. If you're living in the suburbs, you have the luxury of that. If you're living in the city, you don't have that luxury. And so we do have to understand the constraints that our patients are in. And then again, there's a lot of education that needs to play a part in all of this as well. I have this I have a patient who is on a GLP-1, has a family. One of the daughters is obese. The patient has lost a significant amount of weight. She's exercised. But I was talking about food, and I was talking about, yeah, food is really expensive. The vegetables are expensive. And I know, she doesn't really like vegetables. And that's the challenge, right? Losing weight and not liking vegetables is a
Hmm.
huge challenge.
Right.
And so she said, well, the food at McDonald's is cheaper than the food at the supermarket. And I can feed my family a lot cheaper. So there are real constraints that our patients have financially that
Hmm.
increase the risk of obesity just because of the financial constraints.
Yeah, yeah, true, true, so true. I got a couple questions and we only have about 15 minutes left. So let me tackle some of these questions, okay, guys? The first one is it is being stated that, of course, my eyes aren't as good as they used to be. It is being stated that with these new weight loss drug medications, they are actually causing scurvy because of what the patients are not eating and or for whatever reason. Your comments or thoughts on this particular issue?
I haven't seen that specifically. So are they getting enough vitamin C in their diet? I don't know, but the challenge is being nutritionally sound in general is the big challenge for our patients. Um, you have to have a balanced diet. You have to, if you have a diet, let's give an example, right? If you have a diet, say that's high in red meat, red meat has a slow transit time through your gut in general. And now you add that to a GLP-1, right? We're going to slow it down even more. Your desire to eat anything is going to be markedly decreased, whether it's foods that contain vitamin C, vitamin A. You can take your vitamin D, but you run the risk of being nutritionally deficient if you're not really conscientious about a very varied diet.
Right, right. You know, that's true. That's true. But I'm going to go to another question here, and one of our panelists, and I was give me just one. Give me the hold on. I'll explain what I'm doing in a minute. All righty. One of our panelists did not get the email, so he sent us and I was just telling our technical person to please send him an email so he can sign on and ask his own questions. But it says, "Hi Omar, it's Patrick. I can sign in, but as a guest, but not as a panelist. My question is there a renal protective effect outside of the glycemic control of these GLP-1s?"
It's
Uh,
probably related more to the weight loss. We know that your DPP4s are going to have a renal protective effect. Your SGLT2s and are going to have that renal protective effect. Um, there's some belief that it does reduce your risk of kidney disease. The mechanism is not known as to how it does that. whether it's actually the weight loss that's doing it or some other effect inherent with the GIP or GLP-1 medication.
All right. All righty. Good, good. Um, do you think there's a large psychological effect? I mean, let's just step back for a second. I mean, with bariatric surgery, I think to a certain degree there's a large psychological effect with that. Does somebody come into that understanding that they need surgery, they're going to actually change their body and how food is absorbed the way that God gave you it so that you can lose weight, and that's a deep decision. Do you think coming off of these medications or going on these medications, people have that same psychological, level going into this? Because I don't know. I think I maybe put too much into it, but give me your thoughts. And Dr. Sprock, I'll get right to you after this answer. You know, either Dr. Duncan or
I
Dr.
thought maybe
Page,
he
either
wanted to
one.
answer it. I do think it's very interesting. And what I would love to see the study on, because what I see is anecdotal. I see that patients who have other substance use disorder or anxiety disorders, they're the ones who will call repeatedly and insist on a refill of their GLP-1s. So
Mhm.
when we were trying to reduce the utilization of it, there were some patients who complained vehemently about not having their GLP-1s.
Mhm.
And I likened it to, the reason that, I don't prescribe alprazolam, but I will prescribe other benzodiazepines, is because the craving for alprazolam was so much greater than clonazepam, right? So I could reduce the anxiety with a drug, with both drugs, right? But I didn't get the 5 calls a day when I prescribed clonazepam versus when I prescribed alprazolam, which is Xanax.
Mhm.
So I do find that there are certain patients who complain vehemently when they don't have their GLP-1s or when we're saying we're not going to prescribe it anymore. And those are patients who have other types of addictions and who have other types of anxiety. So I would love to see the studies. My findings are simply anecdotal,
Mhm.
but I would love to see the studies on that.
Oh, excellent. Patrick, welcome.
Were you going to say something, Dr. Duncan? I would listen.
Uh,
Oh, go
yes.
ahead.
Really quickly, same kind of the same uh idea is really with regards to studies, they're still very early. But everybody's different, right? So it would be what you would say is anecdotal, depending on said patient. But right now, it really just depends. And then also you have to think about context as well. What kind of pre-existing or core morbid pathologies does this patient have? So just exactly what Dr. Page was saying. If this patient does have underlying substance use issues or they are on looking or have a benzodiazepine that they're on, and I 100% agree, longer acting benzodiazepine tends to cause less problems long term with regard to, even if we're talking about potential dependence. We always taught to look to, Klonopin or Valium to try and wean somebody off when you're looking at that. So it's more of a to be discovered kind of answer with when we're talking about that right now.
Interesting. All righty. Thank you. Dr. Patrick Anderson, welcome, welcome.
Yeah, I apologize. Last week I was too early and realized I couldn't sign on. This week I tried to sign on. I downloaded an app and but happy to say that the problem was on your side of it. But hey, Dr. Page, nice to see you after many years. Dr. Spratt, welcome back. The conundrum I have is surrounding surgery and preparing patients for surgery. And many of our institutions have now policies because everyone is looking to decrease surgical site infections. And so they're asking for strict glycemic control with respect to the morning of surgery, finger stick, 180 or below, or a hemoglobin A1C between 7 and 8. Mm-hmm. And, you know, where we practice, Omar, as you know, because you've consulted nutritionally on many of my patients, is, you know, patients will have a hemoglobin A1C of above 10 for as long as they can remember, and they get put on multiple medications to try and control it. And now they need to have surgery, and the A1C is still above 8. No, so while the ADA says surgery, the decision to cancel surgery should not be made only on A1C results, but we have our anesthesiologists and many of our people in our surgical oversight committees are saying you still can't operate on these patients, you know, and the fight for me is my patients are cancer patients, and I can't always delay an operation waiting for an A1C to come down, which may never come down. Mm-hmm. What are your recommendations for patients with difficulty meeting those standards?
Love it, love it, love it. So GLP-1s, interestingly, just like surgery, bariatric surgery, will drop your A1C dramatically, right? So we would see patients who had bariatric surgery come back with a dramatic decrease in their A1C even before they had a dramatic weight loss. And GLP-1s are also extremely effective in lowering the A1C. And so, you know, it's a medication that you may consider, or that the primary may consider for these patients, as long as they don't have a history of any type of thyroid cancer, right? So it can't be used in that population of patients. So it's something that if you need to get A1C or glucose control rapidly, it can do that. And it will maintain that A1C control as well. Before you came on, Patrick, we were talking about GLP-1s and evaluation of patients for surgery. So because GLP-1s slow the GI transit so much, they're looking at the risk of aspiration in these patients, because you may have told them to fast for 12 hours, but the food may have been in there for 24, 36 hours just because of the slow transit. And so if you are going to use it to lower the A1C, you're going to have to make sure that you're probably stopping that at least about, I don't even know how many days, right? Because the effect is 168 hours, right? So you might have to stop the GLP-1 like a week before surgery, right? In order to get better GI motility so that you don't run that risk of food being in the stomach at the time of surgery.
Yeah, so you know, the recommendation is we stop at a week, but for and Kevin is not on, we do a lot of bowel surgery in the operations that we do. We also give a gut stimulant. We also give Go Lightly, and now we're charged again when we anticipate colorectal component to the operations, add an antibiotic. So now, you know, you're dealing with a gut that's been essentially demobilized for months. And now over 12 hours, 24 hours, we try to recharge it to increase activity so we can get the solid matter out, get the gut stimulant through, and get the antibiotics in through the gut. And I often wonder if that in of itself doesn't put the patient at risk for aspiration at the time of intubation,
right?
Induction of anesthesia.
Right. Have you found with your GI surgeries that there's more waste in the gut than you would expect if you have somebody on a GLP-1?
Oh yeah, we because actually what we do is rectal irrigation prior to even starting an operation, just to ensure that that occurs.
Okay. All right. You know, we talked a little bit about, you know, the foul odor that people get from their breath when they're on GLP-1s for a while. I didn't specifically talk about small intestinal bowel overgrowth, right? So that's something that it's predicted is also happening. And so here, interesting to see that now you're also placing these people on an antibiotic prior to surgery, prior to GI surgery.
You know, and we have, for both of us, our stellar professor, Dr. Sprott, who is always have a physiologic component to his discussion, right? So even when it comes to vitamin production and utilization, we know that gut flora is important in activation production of many of our vitamins, like vitamin K, for example. So now the small bowel, which is typically somewhat sterile, except for the distal, the terminal ileum, right? Now you have bacteria up into the jejunum and parts of the duodenum, which was initially sterilized in the stomach from the acid in the stomach. So how does that impact absorption, activation of some of our micronutrients? I think, this becomes an interesting discussion.
Yeah, definitely, definitely. Well, that may be one of the reasons also why you lose the weight. Because if the acidic or basic medium of a particular area of the gut is not appropriate, then that may inhibit absorption. If we think about it, I'm not sure. I'm sure more studies have to be done on this, but if thinking about, the upper part of the small bowel is where most of your absorption is taking place, then obviously it's an acidic media that comes out of the stomach and the breaking down of food, and it goes into that area to be absorbed. If the medium is changed, and definitely if there's more bacteria, if there's more, I'm not exactly sure exactly what's going on in that area at this particular point, but that's an area of study. Dr. Sprott, please, your hand
Yeah,
is up.
a couple of things. One about the hemoglobin A1C. Um, for those of you in the audience, hemoglobin is found within red blood cells, and it's responsible for carrying oxygen. And what happens with the hemoglobin A1C is that glucose can bind to that hemoglobin. And so when you're talking about a reduction in the hemoglobin A1C, it's not a fast reduction. You can't, drop your hemoglobin A1C very, very quickly because your red blood cells die, some as long as 120 days, but
Mm-hmm.
they talk about 3 months to check the hemoglobin A1C after you have sort of changed your diet to see some kind of an impact. And even with that, it's not, if you go at a 10, you start at a 10, it might go a little bit faster, but it's not going to go very, very fast, especially when you're looking at surgery. And I can tell you, Patrick, my um, patient I know needs to have a pacemaker, replaced because the battery was dying, and they can predict how long it dies. And he had diabetes, and it wasn't under control. And the question was, well, if he doesn't get the surgery with the pacemaker, he could die because
Right.
his heart isn't pacing. And ultimately, they got his sugar down, but his hemoglobin A1C
Was
stayed up. But
elevated.
they did the surgery because they kind of had to. They said, but I think the issue in terms of rapid decline, and it's usually not a rapid decline, even under the best of circumstances. It's a slow process. So if you're looking at it to fall for surgery, you need some time, and sometimes the patient can't wait, and then you need to talk to anesthesiologists about trying to make that happen if you can. But you'd asked an earlier question, Patrick, and that was about renal protection, and the kidney is something I've always had an interest in. You may remember fluid and electrolytes I really liked, but I also like kidney
By the
and
way, that
kidney.
was your lecture that always scared me.
Well, it's interesting. I always like that. But the issue of the GLP-1s and the kidney is that, there's a strong relationship between kidney damage and diabetes that results in the need to have um, dialysis and ultimately transplants if needed. And a lot of the issues related to the kidney and kidney damage may relate to inflammation. And the issue of inflammation, and we talk about nephritis, which means inflammation of the kidney, may play a role. And one of the things that does happen is one starts to spill albumin. And albumin is this big protein that maintains the volume of the fluid within your blood vessels and within the fluid outside of the cells. And so albumin is an important thing in terms of having edema. If your albumin goes down, and it goes down because you might be losing it through the kidney, then you'll start to retain fluid because the volume within your within your blood vessels goes down. And so these GLP-1s tend to stabilize that issue. And so there may be some kind of anti-inflammatory effect that the GLP-1s have on the kidney. And they've noticed that with GLP-1s, people that have had renal transplants, okay, or that need renal transplants, number one, it may delay the time that you need to have a renal transplant. And number two, if you have a renal transplant, you tend not to reject it as frequently as if you weren't on a GLP-1. So there's some things about these GLP-1s that we don't know about. And again, they're knowing that some of these things that we talked about before tend to be good in terms of less alcoholism or less desire for alcohol, but there are some protective things that may be happening that we're not quite sure why they are, but we know that they do. So, there's a renal protective effect of some of the things that end in IL for hypertension, lisinopril, or those kind of things that are usually used to help lower the blood pressure. But they also have some kind of protective effect on the kidneys that we're not quite sure of, but we know that they do. So the GLP-1s, which we said, again, are a natural occurring compound that's been altered by the drug companies, may offer some protective effects on the kidney that we don't know what they are. And it's not just related to improvement in the diabetes. So it's something that they need to look into it, but it does appear to have some protective effects on the kidney. We're not so sure how, the mechanism.
Excellent, excellent.
Well, I have a question for Dr. Anderson.
Go ahead, Dr. Court.
Doctor, what's the level of the A1C that's required prior to surgery? We have to bear in mind that A1C goes back 3 months.
Yes.
Maybe in the month prior to the surgery, the patient was doing very well. Do they have an absolute value of the A1C? What it should be?
It's a range. It's between 7 and 8. But, again, a lot of these quote unquote policymakers, they look at endpoints and not the path to the endpoint. And sometimes some of them don't pay attention to the seriousness of why we want to intervene when we try to intervene. So the range typically is between 7 and 8, but it doesn't necessarily correlate between that day of surgery glucose level, right? And I think what makes sense to me is looking at the trend, because a lot of these patients where the direct monitoring, right? But you can go back and retrieve the data of their glucose, their actual glucose, blood glucose, in the weeks or days leading up to surgery. And I think in my mind, that's a better way to look at the immediate effects of hyperglycemia on surgery, because, if that's what you're going to use to say, put someone to sleep or not, and not pay attention to the 3-month list, because the effect of diabetes on wound healing, on the vasculature it's long-standing, right? If someone has peripheral vascular disease, their risk of infection is going to be present at the time of surgery, whether their hemoglobin A1C is less than 8 in the 3 months leading up to the intervention.
Yeah. Patrick, the two metabolic nutritional people in the hospital, myself and the other guy, we've been talking about this because I think it's become an issue, and seeing how we can play a role as far as helping, the institution as well as the surgeons and the anesthesiologists and the guidelines that the administrative obviously is trying to set. See how we can handle this glycemic problem in surgery. Just to let you know that
and obviously, whether it's an elective operation or most urgent operations are elective versus an emergency operation, that comes into play. But I think it just can't be all or none.
Yeah.
Right.
And it depends on how much time you have to wait, right? But we
Right.
can drop an A1C by about 1 per month. So if you have somebody at 9, I don't know if you can wait a month to get them to 8.
Right.
But with good glycemic control, you're seeing the A1C drop by about 1 per month. But that's that's what that's what a GLP-1 can do. Insulin has its own challenges, right? Because insulin is obesogenic as well, right? It causes weight gain, and may have, and as a result of fat gain with weight gain, fat in and of itself is pro-inflammatory, right? So I don't know, Dr. Spratt, if some of that, when we talk about the kidneys and nephritis, it would be interesting to see a study that really looks at, I don't think a C-reactive protein or a SED rate is going to be good enough to really look at the micro inflammation that happens with fat. But just losing the weight and losing the fat may also decrease your inflammation as well.
All right. Dr. Sprott, you're going to get the last question.
Well, I don't want to take the last question. We got the guests that are here. But I think that it is sort of important that we take into account that the hemoglobin A1C normal levels has been evolving. And so the idea that you kind of want it below 7 um, depends. The older you get, they seem to be tolerating higher levels of hemoglobin A1C than than the 7, and so that needs to be taken into account. And the other aspect is, I think, with the wound healing, is that the vascular supply is different. If you're talking about surgery, sort of more centrally, than surgery that is more peripherally. The issues of the wound healing. That was the issue that I talked about. This patient was the pacemaker where it was. It's the incision sort of central and not very big. And so it ended up not being an issue. I think that given the fact that it was more central, is less likely to be an issue of wound healing there than it would be if it were at the hands or the feet. So there needs to be some common sense approach to these things, and also the urgency of what needs to happen and why needs to be taken into consideration. And people just need to approach it with a common sense perspective on what's best for the patient. You can't look at a number and say, hey, we're going to let the patient die because the number isn't suitable for us to do the surgery.
Yeah.
Sure.
Dr. Page, oh, I'm sorry. Was there something else? Dr. Page, what I'd like to do is there anything that parting words you want to leave the audience? Because this is such a dynamic topic. Any, kind of, I would do this, I wouldn't do that type of thing.
Well, first I'll say, the conversation has been fabulous. I think that the mix of specialties here made it really, really a fruitful discussion. With regards to GLP-1s, it's and GIPs, you just have to use caution. It's not a cure-all. As with anything that you put in your body, you want to give it some thought. How often do you want to put this in your body? How long do you want to put this in your body? We are resilient up to a point. And so I would say that be knowledgeable, be cautious, and make your decision from there.
Mm-hmm.
Omar, I'd like you to get Dr. Page, Dr. Garrison, and Dr. Ali back into space, a bariatric surgeon, a gastroenterologist, and someone like Dr. Page with, vast knowledge of GLP-1s. So we can expand this discussion, because I do believe that there is some nutritional fallout that is yet to be understood. And I'm seeing it more and more in some of my cancer patients who've been previously treated with GLP-1s, who on certain chemotherapy, the mucositis is so severe, and it's up and down the GI tract. So
really,
right.
Yeah,
that's one thing that we didn't touch on, Patrick. Yeah. So we got to get you to sign in earlier.
I know. I know. I tried to a
I'm
week
just kidding,
early.
Patrick. I know you were busy. I'm just kidding. I'm just kidding.
I heard Dr. Page was coming, and I want to make sure I didn't miss her. You know, it's been a few years, right?
I hear
Yes,
you.
it has. And add to that a really good nutritionist,
Right.
like someone that really understands the science
Right.
of
Mhm.
nutrition, right? Because that mucositis is most likely either a deficiency or an overgrowth or of something that's causing it. So, yeah, that sounds great.
Yeah, excellent, excellent. We got to do that. All righty. So, in closing our show, I'd like to thank OB Healthy for bringing this, allowing us to bring this to you. I mean, what a discussion. The platform is great, and we really need we really appreciate their allowing us to do this. Remember, every second Saturday that we're going to have this webinar. All right. All you have to do is just go to our website and understand that you can get the past webinars just by going in the website and hitting our webinar, the YouTube logo, I should say. I'm having a little senior moment here. YouTube logo. Remember, it's caring and sharing, and tell people about it. It takes a village, and we just want to have as many people as possible to join us here. Um, the most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint. I look forward to seeing or connecting with each and every one of you out there in the audience next time. And yeah, join us next month and just spread the word. All righty. Thank you, Cynthia. It was
Thank
a
you.
pleasure. We got to catch up. The rest of the docs, listen, we'll see you next month, guys. Next month, we're going to all be here. We have Dr. Warren coming in, and she's going to have a powerful topic that she's going to be talking about as well. All righty. So until next month, I'm going to say peace.
All right. Peace.
All right. Take
Good
care,
night,
everyone.
everyone.
Hey,
Happy
All right.
Cynthia,
Valentine's Day as well.
Yes.
Yes.
hang on a
Take
second.
care.
Okay.
Take care.
Good to see everyone.
Care.
Where in Louisiana are you?
I am in New Orleans.
Oh, okay. Yeah.
Yes, I've been there now for 2.5 years. Hopefully getting out of there in about another 6 months or so, and we'll see where I go at that point.
Think about
I
Florida.
went to
Think about
Xavier
where?
University.
Florida,
So
Sarasota.
yeah.
Yeah, I definitely want it to be in the South.
Yeah. Okay, take
All
care.
right, thank you. All right, bye-bye.
Bye.